Assalamu alaikum. This is Professor Tamer Youssef, a professor of general endocrine surgery. Today we are going to discuss the surgical anatomy of the thyroid gland. Regarding the embryology of the thyroid gland, the gland is chiefly developed from the thyroglossal duct. This is the median bud of the pharynx. It commences at the foramen cecum at the junction of the anterior two-thirds and the posterior one-third of the tongue. Then it passes downwards, either in front, behind, or through the hyoid bone. It reaches down to the thyroid isthmus, where it forms the isthmus and the major part of the two lateral loops. The second organ is the ultimobranchial body, which arises from the diverticulum from the fourth pharyngeal pouch of each side, in which they amalgamate with each other to form the lateral part of the two lateral loops. The parafollicular cells or the C cells develop from the fifth pharyngeal pouch, and it is of querineural crest origin. So they consider these C cells a part of the Apud system. It is the abbreviation of amine precursor uptake and decarboxylation. The parafollicular cells is the origin of the medullary carcinoma of the thyroid gland, which is the only functioning tumor of the thyroid gland, and it will be discussed in detail in the lecture of thyroid neoplasm. This is a figure showing the thyroglossal tract. Regarding the anomalies of the thyroid gland, we may have a congenital aplasia or aplasia. This will lead to the development of cretinism, congenital hyperplasia, which may predispose to congenital thyrotoxicosis. The third is very important with the ectopic thyroid tissue. We have three types of ectopic thyroid tissue, either lingual, cervical, or intrathoracic. Let's agree that all ectopic thyroid tissue should occur in the midline of the neck. There is no ectopic thyroid tissue outside the midline of the neck. So the first type is the lingual thyroid. This will be presented as a round swelling at the back of the tongue at the site of the foramen cecum. This lingual thyroid may cause dysphagia, impairment of speech, respiratory obstruction, and rarely hemorrhage. Beware that this lingual thyroid may be the only thyroid tissue, so you have to do a thyroid scan to detect if it is the only thyroid tissue or not. Treatment aims at reducing the size of this ectopic thyroid by giving L-thyroxine, excision surgically, or ablation by radioactive iodine may be needed. Then we have the second type, which is the median ectopic thyroid or the thyroglossal ectopic thyroid. As I have mentioned, it should be in the midline of the neck. Again, it may represent the only thyroid tissue. The third type is the true intrathoracic ectopic thyroid tissue, which would be presented as a mass in the superior mediastinum if it gets enlarged. So, we have what we call lateral apparent thyroid. Lateral apparent thyroid is not an ectopic thyroid tissue. It is a lymph node metastasis from an occult papillary carcinoma. It occurs in the young females from 20 to 30 years. So this patient will be presented with a mass in the lateral part of the neck. When this mass is biopsied, it will reveal papillary carcinoma of the thyroid gland. So again, lateral apparent thyroid is not an ectopic thyroid tissue. Stroma ovarii. Stroma ovarii is a German sentence, means that this patient have got an ovarian teratoma. We all know that ovarian teratoma can give rise to any type of tissue. One of these tissues are thyroid tissue. So, stroma ovarii is not an ectopic thyroid tissue, it is an ovarian teratoma. So, the term lateral apparent thyroid, the term stroma ovarii is not an ectopic thyroid tissue. The thyroid gland is an endocrine gland which is responsible for the secretion of thyroid hormones, namely T3 and T4. It is situated in the lower part of the front of the neck. It consists of two lateral loops connected by a midline isthmus, and there may be a pyramidal loop arises from the isthmus and is connected to the hyoid bone by the levator glandii thyroidi muscle. The average weight of the normal thyroid gland is from 20 to 30 grams. The apex of each loop reaches up to the oblique line of the thyroid cartilage, while the base is at the level of the sixth tracheal ring and the isthmus lies at the level of the second, third, and fourth tracheal ring. The thyroid gland has two capsules, the true and the false capsule. The true capsule is the anatomical capsule of the thyroid gland. If you open it, you are inside the gland itself. But the false capsule is very important and it has another name, which is the pretracheal fascia. This capsule invests the thyroid gland. It is derived from the deep cervical fascia. Upward, it is attached to the oblique line of the thyroid cartilage. Laterally, it is continuous with the deep cervical fascia of the neck, and inferiorly, this space is open by being continuous with the fibrous precardia. The surgical importance of this pretracheal fascia of the false capsule are: number one, it is responsible for movement up and down of the thyroid gland with deglutition. Number two, retrosternal extension. Number three, compression manifestation in case of huge goiter. And you have to know that benign goiter only causes tracheal compression. If there is compression upon the esophagus or the recurrent laryngeal nerve, this may be due to a malignant thyroid or due to retrosternal extension. And number four, there is a thickening in this pretracheal fascia between the cricoid cartilage and the posteromedial aspect of the thyroid gland. This is called the ligament of Berry. This is very important surgically because the recurrent laryngeal nerve lies behind it, and it is liable here to be injured during the operation of thyroidectomy. Regarding the relations of each loop, we have anterior relation, medial relation, and posterior relations. Anterior, the loop is related to all of the infrahyoid muscles except the thyrohyoid. So it is related to the sternothyroid, the sternohyoid, and the omohyoid. These pretracheal muscles or the infrared muscles are supplied by a nerve called ansa cervicalis, which arises as a loop from cervical 1, 2, 3 segments. Medially, the upper part of the gland is different than the lower part. So the upper part is related to the cricoid cartilage, thyroid cartilage, and the cricothyroid muscle with the lateral wall of the pharynx, but more inferiorly, it is related to the trachea, esophagus, and the recurrent laryngeal nerve in between. Posteriorly, each loop lies upon the carotid sheath, containing the carotid artery, internal jugular vein, and the vagus nerve. Arterial supply of the thyroid gland consists of three arteries and a fourth accessory artery. So the main three arteries are the superior thyroid artery arising from the external carotid artery, the inferior thyroid artery arising from the thyrocervical trunk arising from the first part of the subclavian artery, and the thyroidema arteries which arise from the arch of the aorta or the innominate artery. We have accessory arteries from the trachea and the esophagus. Please review the other branches of the external carotid artery. We have the abbreviation some, American, ladies, found, our, pyramids, so many. Please review your anatomy. Venous drainage consists of the superior thyroid vein, the middle thyroid vein, which drain into the internal jugular vein, and we have the inferior thyroid veins, not one vein. There are multiple veins draining into the left innominate vein. We may have a fourth vein between the middle and the inferior thyroid veins called vein of Kocher or Kocher vein. This may present in some cases and it should be ligated to avoid injury of the internal jugular vein. So, we do not have middle thyroid artery. There is no middle thyroid artery. This is a diagram showing the arterial supply. This diagram shows the venous drainage and the lymphatic drainage of the thyroid gland. Regarding the lymphatic drainage, the thyroid gland drain into the upper and lower deep cervical lymph nodes. The medial part of each loop drain into the central group of lymph nodes, which are the prelaryngeal lymph node. This is called Poiré lymph node, and the pretracheal lymph node. This is called Delphic lymph node. In surgery, we have some nodes which are named, like these two lymph nodes. We have also the Virchow lymph node, the left supraclav, which is enlarged in case of abdominal malignancy. We have the Reuter's lymph node between the pectoralis major and minor. It is important in case of carcinoma of the breast. We have other nodes. You should review it. Regarding the histology, the structure and functional unit of the thyroid gland is the thyroid follicle. We have about 30 millions of thyroid follicles in each gland. The size range from 0.05 to 0.5 millimeter. It is rounded or oval. The lumen is filled with a colloid named thyroglobulin. The wall is lined by low cubical epithelium lying on a thin basement membrane. The cells lining the follicles are of two types, either the follicular or the parafollicular cells. The follicular cells constitute about 98% of the cells, and these are the cells responsible for secretion of the thyroid hormones. We have a very specialized type of cells, which are the C cells or the parafollicular cells. It constitutes 2% of the cells. These develop from the fifth pharyngeal pouch, and they secrete the hormone calcitonin, responsible for lowering the serum calcium level in blood. These are the origin These cells are the origin of the medullary carcinoma of the thyroid gland, which is the only functioning thyroid tumor. The principal hormones secreted by the thyroid are the T3 and T4, triiodothyronine and the thyroxine. Their synthesis is controlled by several enzymes and pass into the following steps. Number one is the step of trapping of the inorganic iodide from the blood, then oxidation of the iodide into iodine, then binding of this iodine with the amino acid tyrosine to form the iodotyrosenes, then the process of coupling. If you couple a mono to a diiodotyrosine, you will get the T3. If you couple two diiodotyrosenes, you will get the T4. When these hormones are required, the complex is resorbed into the cell and the thyroglobulin is broken down, releasing the T3 and the T4. In blood, T3 and T4 exist in two forms. Either they are bounded to TBG, thyroxine binding globulin, or the free, which is the active form in the blood. T3 acts quickly in about few hours, but for the T4 it acts more slowly. It takes from 4 to 14 days to act. So T3 is the more important physiological hormone. It is also produced peripherally in the blood by conversion of T4. We have a family of immunoglobulin G known as thyroid stimulating antibodies. They can activate the TSH receptors on the follicular cell membrane. They have a more protracted action than the TSH itself. So, the TSH will act within 16 to 24 hours versus 1.5 to 3 hours in case of thyroid stimulating antibodies. And these antibodies are responsible for virtually all cases of thyrotoxicosis, not due to autonomous toxic nodules. But the serum concentration of these immunoglobulins are very low, so it is not routinely assayed in laboratories. So what is goiter? Goiter is enlargement of the thyroid gland. Normal thyroid gland is impalpable. So whenever it is palpable, this is called goiter. Goiter may be simple goiter, toxic goiter, neoplastic goiter, inflammatory goiter, or thyroiditis, and others. Simple goiter may be diffuse, which are the physiological and colloid goiter, nodular, which are the simple multinodular goiter, and the STN, the solitary thyroid nodule. What's meant by simple goiter? Simple goiter means that the patient is euthyroid. There is no manifestation of hyper or hypofunction. Beware that STN, when diagnosed, should be diagnosed both clinically and by ultrasound, because 50% of clinically STN will be multinodular goiter or dominant thyroid nodule by ultrasound. The toxic variety is the diffuse type, or the primary toxic goiter, the Graves' disease. The secondary type, which is the nodular toxic goiter, and the tertiary type, which is the toxic adenoma or autonomous toxic nodule. Here there is hyperfunction of the gland. Neoplastic thyroid may be benign or malignant. Inflammatory include autoimmune. The most important is the Hashi or Hashimoto thyroiditis, granulomatous, which is the T-Girvan thyroiditis, fibrous, which is the Riddle or Woody thyroiditis, infective, which may be due to viral or bacterial infection, and others, which are the amyloidosis. At last, we have two nerves related to the thyroid gland. This nerve do not supply the thyroid gland, but it supply the larynx. But it make relation to the thyroid gland. These are the superior laryngeal nerve and the recurrent laryngeal nerve. The superior laryngeal nerve is a mixed motor sensory nerve. It gives two branches, which are the internal laryngeal nerve. This is a sensory nerve supplying the mucous membrane of the larynx above the level of the vocal cords. Its injury will lead to shocking. We have the external laryngeal nerve, which supply only one intrinsic muscle of the larynx. This muscle is the cricothyroid muscle. Injury of this nerve lead to loss of high-pitched voice. How to avoid injury? You should ligate the upper bowl of the thyroid gland within the gland, not away from the gland. If you ligate the superior thyroid vessels away from the gland, you will injure this nerve. We have the recurrent laryngeal nerve, which is a mixed motor nerve. It has no branches. It supplies all the muscles of all the intrinsic muscles of the larynx except the cricothyroid, and the sensory part supply the mucous membrane of the larynx below the vocal cords. The manifestation of this nerve injury will be discussed with the clinical seminar of thyroidectomy. But to avoid injury of this nerve for the time being, you should ligate the inferior thyroid artery away from the gland, because this nerve, the recurrent laryngeal nerve, pass either in front or behind the main trunk of the inferior thyroid artery or its branches. So if you are going to ligate the inferior thyroid artery, you should ligate it away from the gland, or you should see the nerve and ligate the branches selectively to avoid injury of this important nerve. At last, thank you for listening.